Good evening, everyone. I hope I'm audible.
You are audible, Dr. Mkiri.
Oh, Frank, you're in. How are you?
Yeah, fine, thank you. I got late a bit, but
Now you're in.
yes, now I'm in.
Okay, so I
So
think
let
you
me
can.
just start. Okay, you can see me?
Yes, we can see you and we can hear you.
Okay, I think so far we have 32 participants. So welcome all. I think we are right on time. So welcome to this bi-weekly CME that we usually have, hosted by Ophthalmology Society of Kenya. And I'll take this opportunity to greet you. I hope you have had a wonderful day as we are closing up the day. So today we'll have a presentation, and to welcome the moderator who will introduce the topic and the presenter. We have Dr. Mukiri will be the moderator. Dr. Mukiri is a consultant ophthalmologist. He's also an anterior segment specialist, and is also a lecturer in the University of Nairobi. So welcome, Dr. Mukiri, to present both the topic and the presenter. Thank you very much. Feel welcomed. You can all post your questions and your comments on the chat group. And it's an interactive session, so kindly feel free to interact. Thank you very much. So, Dr. Mukiri.
Okay, thank you, Frank, for that introduction.
Yes.
Welcome to today's CME. Today we are privileged to have a very prominent oculoplastic surgeon by the name of Dr. NYENZE. He is a lecturer at the University of Nairobi and trained his oculoplasty subspecialty in Aravind and LVPI in India. And on top of being that, he was previously editor-in-chief of the COEXA journal. So he's a well-rounded ophthalmology, both in practical and in research aspect. Today, we are going to go through part 2 of a session he had carried out before. That is the practical approaches to eyelid surgery. He said it's a very wide topic, and he promised to come back and complete it. So he has come to fulfill his promise. So without further ado, Dr. NYENZE, the floor is yours. Karibu sana, Daktari.
Thank you so much, Dr. Mukiri, for such a kind introduction. Let me try, first of all, the basics first. The host has disabled the sharing of screen. I need to start sharing. Let's check on that first.
You can go ahead, Doc. Go ahead.
Let me try again. Are you able to see my screen?
Yes, we can see the screen, but you can put it in presentation mode. It's not yet there.
Oh, I had already put on presentation mode. Do I try again?
You can try again. If it doesn't, then just enlarge the slide.
And now, are you able to see?
We can see your screen. Where is it?
And the presentation?
Okay, I've lost you. Maybe it is me.
No.
Frank, you can see the screen?
Yes, we can see the screen.
You can see the screen?
Yes, Dr. Nyenze, the screen has come on, but without the presentation.
Okay.
You can see your desktop, yeah.
Let me check.
Actually, you are, yes.
Is it better now?
Yes, can you press F5?
F5.
Okay, still not working.
Wait a minute. I'll see something.
Yes, perfect.
Perfect.
Yes, perfect.
No, it's okay.
Okay.
Okay. So good evening, everyone.
Good evening to you.
Welcome to my presentation, and thank you so much, Dr. Mukiri, for your introduction. Yes, I attempted to do a presentation on approach to eyelid surgery. And as I was doing the presentation, preparing the presentation, I realized the ideas I had could not be contained in one presentation. Even then, it still ended up to be a very long presentation. But I said I'll be back. And I'm back, and I'll see whether I'll attempt and see whether I can do more on that. But I'm sure some of you might not have been there in the first presentation. So I'll do a quick recap of what I presented before I move into a few cases that are presented. My approach was to see some cases that I've learned a few lessons on eyelid surgery from. This is not so much of textbook stuff. This is stuff that I have found in the field and what I've learned, and I found it important that I should share what I've learned in the field of oculoplastics. So if the ones who are there last year, they can remember I presented this case of a patient who had a lid laceration. Attempted repair was done, but it ended up becoming a messy affair because immediately after surgery, when the patient presented, they looked like there is a big defect on the upper eyelid. This is after the repair. This is how the patient looked like. And this is how the patient came to me, looking like 2 weeks after the surgery, with a very big, more than around 70 to 75% upper lid defect of the affected eye. So that's how the patient presented to my clinic. Well, I realized when I saw the original photos, I knew that there is a mistake, especially on the original surgery. And we always say that the original surgery is always the first surgery, or the original surgery should be done in the best way possible. If the first surgery is done well, then probably you save the patient from another surgery, and also the cosmetic and the functional effect is much better. So I mentioned a few tips on what to do before you attempt repairing a lid laceration. Assess, the first thing I say is you need to assess whether they are actually lid defects. This is important because sometimes a patient's contraction of the orbicularis muscle makes the eye look like there is a very huge defect. But when you try to stretch out tissues, you realize that there is no defect. I've been called for review or to see patients who have been patients with the reports that come and review a patient with a huge lid defect. But during surgery, like in this case, during surgery, you realize actually this lid like the case that I've just shown, that this patient does not even have any lid defect at all. So that one you have to be very clear. Of course, before laceration repair, look at the drainage system and see whether it is okay. Look for lid margin injury, because of course you know that lid margin repair is different from the rest of the special in a way. Again, assess for medial canthus avulsion injuries. Avulsion injuries, when they are not repaired well, the patient loses the contour of the eyelid and has a very poor cosmetic effect if the medial canthus is not returned, the tissues are not returned properly to the medial canthus. So, of course, during repair, what do you have to do? You make sure that there is proper alignment of tissues. Try to stress the flaps to the original place. Sometimes the injury, like the one I showed before, is totally complex, but it looks, in most cases, it looks like a jigsaw puzzle where you have to try and solve it. And once you do that and you get it right, you realize there is no lid defect and the lids and the tissues go back in a very well way. Canthal, again, be careful when there is an avulsion injury from the medial canthal tendon. You have to return the tissues where they are supposed to be so that you maintain the eyelid contour. Of course, the lid margin, you have to repair it in the right way. I'm not going to I'm not going to discuss that because I'm sure everybody knows that you start with the marginal suture, you know how to place it. Tarsal plate repair is done second, then you do a lash line and you do the skin. So that one you should know. If there is a canalicular repair, then that is very important that you try and repair the canalicular repair primarily. And that is probably, I would say that's a topic for another day. Mostly we try to use a monocanalicular stent in a repairing of, locally, even though they are not available of late, but stenting is important, and the most commonly used stent nowadays is a monocanalicular stent. So, of course, you have to choose the appropriate suture. You need a small suture, especially for the skin, to avoid the suture lines to be that are visible. Preferably nylon if it's an adult. Children, you need absorbable. I prefer monofilament sutures because they don't cause a lot of granulation. But Vicryl, if it's available, is good. You need to use a stronger suture, like a 5-0 Vicryl, or as I said, absorbable this time round, 5-0 for the tarsal plate. Remember to take small bites so that you don't sacrifice the skin. Avoid vertical sutures because that can cause an ectropion. There's some people who advocate for primary ziplasty if there are vertical lacerations. And then, of course, if you assess nicely and you realize there is actually a defect, then the defects can be managed accordingly, and I'll discuss that as we go ahead. So the other case I presented of that time is a case of malignant eyelid lesion. We have seen an extensive, a large eyelid lesion which had been seen in peripheral in other facilities and did not manage appropriately. Then I thought I should discuss malignant lesions, and we discuss or look at what could probably have gone wrong and what is the best way to prevent or to treat malignant lesions. So in small lesions, how can you tell that this looks malignant? Because you don't want the lesion to grow big, to become obvious. So eyelid swellings are one of the most common presentations. And when a patient presents with an eyelid, a small malignancy, then you should get it. It's very important that the diagnosis is made at that moment because the treatment is very different. So the signs of malignancy, as I discussed of that, is destruction, destruction of lid margin architecture. You remember the lid margin itself as usually as a rounded anterior border and a sharp posterior border. So if the border is if the border, the lid margin architecture is damaged, then that is suggestive of a lid malignancy. Loss of lashes, like you can see in this case, there are no lashes. You can see the lashes, you trace them and they are not there. Even in this lesion, you can see there is loss of lashes. Irregularity, look at these lesions. Most benign lesions are usually totally regular or well-defined. This one is, if you look at these lesions, most of them are irregular. Attachment to underlying tissues. Superficial lesions like cysts, when you palpate or you touch them, they are usually mobile. Deep ones may not be, but attachment to underlying tissue could be a sign of malignancy. Ulceration, and the ulceration in malignancies is different. Usually in malignancies, the borders are usually pearly and also elevated. Another sign is telangiectasia, that is the dilated vessels. Recurrence, lesion recurrence after repeated, after excision. Like we have seen in cases of lesion, I've seen cases of lesion that have recurred after excision and they turned out to be malignant. So recurrence of a lesion after excision is a strong sign that that could be a malignancy, and you have to be very sure. Of course, most of the lesions in the eyelid lesions, benign lesions, progress is slow, so rapid progression is also a sign of malignancy. So with that, when you suspect a malignancy, the surgery has to be, there is a specific way of handling conditions that are malignant. Wide excision, at least 4 millimeters from the lesion. Ideally, you should do marginal clearance. You should do clearance surgery, marginal clearance, before you continue with the reconstruction. There are 2 ways of doing that: is a frozen section and the most microsurgery. Unfortunately, they are not available widely in Kenya. I know there is frozen section in Nairobi Hospital, and I think also Aga Khan Hospital, but not many hospitals. In our setting, we try to do the same. We do surgery like a week to both surgeries, a week in between, and we take for histology and communicate with the pathology team so that they can they can do the reporting within that week, if you cannot do the frozen section or most microsurgery. But ideally, you should not repair the defect in a suspected malignancy before you get the report that the margins are clear, because after that, if the margins are not clear, the other surgery is actually very tricky. If the margins are clear, then you need to do marginal clearance. Resulted defects also have to be cleared and a close follow-up. The other thing we discussed was repair of full thickness defects. The principles of repair of full thickness defects is first of all, you use the simplest possible procedure, like tissue to like tissue. You avoid using 2 free grafts at the same time. Like in this case, we did a lead sharing procedure and it turned out very okay. If the first assessment, as I said, is look first, is the lead defect more than 60%? If it's more than 60%, some people say up to, some people say 50, but on average 60% defect, then just do a lead sharing procedure, which can be catalabia or use procedure. This was I discussed in detail during the other presentation, so you can get that presentation, is there on YouTube. If a defect is less than 60%, then you can try primary closure. If it doesn't work, you do canthotomy, cantholysis, and if it doesn't work, you do a rotational flap like a tensile flap to assist. The third case I presented today, the third case is a new case that I'm presenting today. This is a 55-year-old patient who presented with bilateral eyelid swellings. She had similar swellings scattered all over the face, upper arms and trunk. She had been seen by a dermatologist before, and an histological diagnosis of seborrheic dermatitis was made. On examination of the patient, she had bilateral pigmented eyelid swellings with multiple other smaller swellings scattered all over the face. There was a mechanical ptosis of both eyelids, and there is a ectropion, mechanical too, on the left lower eyelid. You can see on the picture, both eyes are involved. The huge lesions causing ptosis, and the ectropion on the left lid, and smaller lesions, especially on the right upper lid. Of course, a diagnosis has been made of a seborrheic keratosis histologically. These are benign conditions which are usually pigmented. They typically have a stuck-on appearance on the skin. They usually affect the face, the trunk, and arms, especially areas exposed to the sun. Most of the lesions are not as extensive as we have seen. They're usually few, and surgery is usually for cosmetic purposes. Therapeutic purposes are maybe if there is causing ptosis or ectropion like you have seen in this case. So these are benign lesions. So what is the practical approach of benign lesions? Benign lesions, of course, you don't have to be aggressive. So margins are not generally required. Sometimes even, margins are usually not required. And you do not have to excise both lamella like you do in, I didn't mention that clearly, but if you suspect a malignant lesion, please remove both lamellae. I mean, do a through and through incision and remove anterior and posterior lamella. But if it's a benign lesions, then you just remove the anterior lamella that is involved. So for this case, what approach did we have? This is a very extensive case, and there are very many lesions. So I decided to do one eye at a time under local anesthesia because of the extent of the surgery. The lower lid had lesions. I decided to excise the lesions of the lower lid. You remember I said you don't have to remove the margins, so I even left a small lesion over there. It can be done later if need be, because I'm also concerned with the defect that I'm leaving. And then I fashioned a nasojugal flap from around. You can see the flap the way it is. Then reflected the flap to cover the lower lid defect because it's an anterior lamellar defect, so the conjunctiva and the tarsal plate are intact, so there's no problem with that. The upper lid, again, I excised there's a medial lesions around there, I excised it. I fashioned a glabella flap, and you can see on the second picture, I moved it and it covered that defect very well. Then I removed the remaining upper lid lesions, the large ones. Remember, you don't have to remove everything in this case. I removed the large ones, and those ones I covered with a full thickness skin graft. So by this time, everything is, all the tissues are well covered. So on the other lid, I realized it's just mainly on the upper lid. So again, I excised the whole lesion and I covered it with a full thickness skin graft on another setting, and excised the smaller lesions that were surrounding, and some of them closed primarily, and others I just very tiny ones I left them to heal secondarily. So that's how I managed, and the purpose of this discussion is to see the way a little bit to handle anterior lamellar defects is a little bit easy, especially so for an older patient, because you have a lot of loose tissues around. You have two options. You can now do flaps. The flaps that you can do for anterior lamellar flaps, you already mentioned a tensile flap. I'm not going to back to that. I've mentioned an nasojugal flap. I already shown you what I did in that case. That is what I did. We have what we call a fecal flap, where the skin of the upper lid, the skin fold. The upper lid skin fold is usually a free skin that can be used for reconstruction. Being careful not to cause an ectropion. That is, in an older patient, you can get a lot of skin from there, and then that can be fashioned like a flap and reflected to the lower lid. That's quite a very easy surgery to do. There is what we call, you don't have to remember the names, but it's important to get the concept. The tipier flap, where the flap is removed from the eyebrow or above the eyebrow. That is in case you don't have a good lid fold, because this skin is a little bit thicker, but it works a little bit. It works in the situations that is not possible. You have already shown you a glabella flap, how it can be used. Then sometimes a master cheek, where is a full cheek rotation. This is mainly done by plastic surgeons and maxillofacial. It's not, I've never done it myself. It's quite a large flap to do. So that's how you do flaps for the anterior lamellar defect. Why flaps? Why not full thickness? Both of them, as you've seen in that case, I actually did both because both of them are very good for the covering for anterior lamellar flaps. Flaps, they have a higher success rate because they're actually vascularized. Of course, surgery takes less because you don't have to, you remember full thickness skin graft, the way you have to migrate the skin, prepare it and put it. Quicker or faster recovery because of course it's vascularized and the skin color most of the times is maintained and it contracts less. The problem with flaps is that if you're not careful, you can create a large defect in another place or even cause another damage. Like if you lift, you get a very big flap. If you're not careful with the upper lid, you can actually cause an ectropion or even another defect on the upper lid. So that one you need to be careful about. Full thickness skin grafts, you can be more, you can cover even a larger defect without causing a big problem. And even the area that you get it is usually not a very sensitive area. You can actually graft a split thickness and cover the defect. It takes longer, of course, to recover. You have to actually, in most cases, you have to cover that defect with a bolster for at least 5 days. It is not, the uptake is less than a flap. It contracts more than a flap, and sometimes the skin color might, especially initially, the skin color might look a little bit different, but it still takes up in future. So if you can do a flap, that works very well. If you can't, then full thickness is actually good. But why full thickness, no split thickness? Full thickness skin graft is for anterior lamellar defects is very good because of course it gives a good color to the lesion. In future, sometimes you don't even know whether there is a graft which has been put. It has a lower contraction rate than a split. No, it contracts less than a split thickness graft. The surgery is actually easier for us ophthalmologists. It's faster. Most of the times, if you are to do it, you use plastic surgeons. If you are not familiar with the harvesting of split thickness grafts, it's a thick graft, so it takes less than a split thickness. You can't use it for a large area because, of course, you'll create a big defect in the area that you're going to live. So you only use it for a small defect. And of course, it cannot take if you place it on bone. You have to place it on a place which is vascularized. Split thickness grafts, of course, they cover large areas. They can be placed on bone. So in case you have a frontal region defect, then you need to cover that area with a split thickness. Sometimes you cover that with split thickness and then use a full thickness for the rest of the eyelid. They contract more. The color and texture of the skin can be different. Those are the disadvantages. It has a better uptake. And the surgery is a little bit more complex at full thickness. That's what I feel myself. Mainly because I don't have a lot of experience with harvesting the split thickness defect, but it's also not very difficult. So full thickness graft is not, it's very good. And more so in cicatrical ectropion. We have seen these, like the case that you're seeing here, a patient with a burns, severe facial burns, develops very bad exposure, ectropion. In that case, it is probably the only option because you can't do flaps because the rest of the face is burned. In these cases, one thing that I've realized is that most of the times the burns, chemical burns, this happens, this kind of condition you'll also see it in upper exhaust ophthalmica. Most of the times the posterior lamella is well spared, and the lid margin in most cases is also well spared. So in most cases, like you can see here, you have good lid margin. It's only a little area here that is missing, but this lid margin is almost enough to come and cover the whole eye. So you need to release it carefully, not to damage also the levator. You stretch the tissues back, and then of course put a full thickness graft. Where do you harvest it? I think most of you are familiar. You look for the thinnest skin. The best skin would be the lid, upper lid of the other eye. Of course, you mentioned there is the skin fold is usually available for that, but most patients will not accept due to touch a normal eye. They will not accept. So we usually go for postauricular region or preauricular in some cases. If some patients have very extensive burns, those areas are not available. So you could try the inner arm or even the supraclavicular region. One point that I always say, I always insist on is a bolster to put pressure on the graft. That really increases the chances of uptake. We usually do that and keep that bolster for like 5 days. Initially, I used not to do that bolster, or I could remove it within 2-3 days, and the uptake was not as good as putting proper bolster and keeping it for 5 days. It just means that the graft is not going to miss to move, and it is well apposed to the skin. So these are another example of a patient with a similar presentation. These are very common presentations. These are cases, especially if there are some people I'm sure have joined us in areas where there are no plastic surgeon. I've seen pictures, some people have consulted me with pictures, and it's difficult to explain to you that this is not a very difficult surgery to do. After releasing the contractor, the tissue just moves by themselves, and then the defect is well defined. And of course, you harvest, like I can't remember where we harvested for this child, and we put both sides. This is just the first day of opening, and you can see the skin has already taken on the first day. You can see it's already reddish after opening. That is 5 days after surgery. So the full thickness skin graft works very well. So that is those cases define anterior lamellar defects. I think today I'll go for one more case that I find it very interesting, and this is a lid retraction. So for this lady that presented to our clinic with a patient on treatment of Graves' disease, came with an eyelid retraction which was affecting the right eye. The patient complains the right eye looks larger than the left. That is what they always say. And then examining the patient, of course, revealed that there is the right upper lid, there is a retraction, and there is actually a mild proptosis of the right eye. I have a keen interest of eyelid retraction because it is one of the most common presentations in patients with thyroid orbitopathy. And it is the one that contributes most to the poor cosmesis effect of this condition, not even the proptosis. It is the one that makes patients have that look like they have a staring kind of look, and they are actually like they are scared or terrified by something. So, and of course, in most cases, they make the proptosis look worse than it actually is. And in some cases, it contributes to exposure keratopathy, because even though the patient could have a good belt, the eye is still sometimes remains exposed. So what I realized is that in most cases, if you handle a lid retraction in patients with thyroid orbitopathy, of course, the thyroid orbitopathy is a big topic, so I can discuss it, or we can discuss it on another day. But I have realized that in many patients, I've just tackled the lid retraction, and the patients were very happy. To know how the patient will look like if you just tackle the lid retraction, I usually just support the lid, like you can see in this picture. You support the lid down as the patient looks straightforward. And you can see, like now, if you look at the right eye, it looks like the proptosis there is a lot of proptosis. But you just tackle the lid itself, you realize actually now the proptosis looks worse on the left eye, which has mild lid retraction. So in that case, lid retraction is handling of lid retraction is a skill that I find very, very useful. And as we go forward, you realize that this is a very easy also procedure to do. Actually, might not even need an oculoplastic surgeon for that. The teaching has always been Levator recesion for lid retraction, but there is a procedure where some people are trying to promote as plastic surgeons called blepharotomy. I like this procedure because it's Levator resection, of course, has advantages. The outcome most sometimes is better, but it's a little bit more complex. It's very hard to identify levator muscles. Even for a plastic surgeon, sometimes you get lost looking for the levator muscle, and it is usually a longer procedure. Blepharotomy, the outcome is not bad in most cases. It's easier to perform and it's a shorter procedure. What is blepharotomy in short? Blepharotomy is a procedure where it can be an anterior or a posterior, it has an anterior or posterior approach, but I discuss the anterior approach because it's the easier one. In blepharotomy, what you do is you divide the lid, the upper lid. The first incision, of course, is laid at the lid margin, and then the lid is split into, the incision is extended to be through and through. Some people say that you cut through and through, but that one is a little bit, it doesn't respect the tissues. So the best thing to do is to, first of all, cut the skin, dissect slowly to see the end or the upper border of the tarsal plate, and then to separate of course, the upper border of the tarsal plate. What is covering that area is the levator muscle aponeurosis, the levator aponeurosis on top, and the Mueller's muscle. So you separate those two from the upper part of the tarsal plate, such that you get a gap in all, and you can see the cornea. Like I see in this case here, you can see the cornea through your incision. Now, when you do that, you start with a small gap. You release a small gap, and then you can tell the patient to sit up and see whether the retraction is taken care of. If it is not, you can extend the gap a little bit more. Ask the patient to sit up again and see whether the retraction has been sorted. Do that until the retraction is fully and well and satisfactory sorted. So sometimes you can almost separate the whole extent of the tarsal plate from the Mueller's and the levator aponeurosis and get a very big gap in all. So when you start suturing, you don't suture that all. You just suture the skin with a small bite of orbicularis. So you suture the anterior lamella and leave the posterior lamella unsutured. That's why I'm telling you, it takes it's a very short procedure. And then you wait for the healing to take place, and the patients, the problem will be solved. So, and that is exactly what I did for this patient. I did a posterior blepharotomy. Unfortunately, I got a mild ptosis, so this one was, I really overdid it. I've done a few cases which the outcome was very good. Unfortunately, I don't have the pictures for that. But the patient is very happy with this. The mild ptosis is, of course, much better than a lid retraction that is tearing on people. So that is, I'll end my presentation at that. I still have a few topics for eyelid, a few conditions that I can discuss, but today I decided not to put so much. Probably there could be another presentation on the same if you give me the opportunity. Thank you so much for listening.
Okay, thank you, Dr. NYENZE, for that wonderful presentation. Very practical, very clear. We have learned quite a lot. I've learned about blepharotomy today. I don't know if you'll allow me to practice it as well, but
yeah, it's true. It's something that I'm trying to show things that even a general ophthalmologist can do. Yeah.
Yes, it's quite true. Because many people come with lid defects, whether it is due to trauma or other things, and when you refer them, they don't come. So if somebody is equipped with the right skills to do them at the base hospital, why not? So I'm looking at the chart. It looks like everything you presented was very clear. Cannot see any questions. Frank, anything on your side? Dr. Nyakago?
No, not yet. But maybe somebody can raise his hand and maybe can ask a physical question.
Sure.
I've seen a question. There is a question, I think, from Dr.
Yes.
Frank.
There is a question. Let me see. From Dr. Mark Nganga. He says you have a very good presentation. Kindly mention on mild ptosis.
I did specifically go to ptosis because that is a very big presentation. That's a very big topic in itself. Maybe if we get time, I can do that. But yes, mild ptosis, the mild ptosis means, of course, that the chances are that the levator function is working well. Chances are that the levator function is good. So in most cases or in some cases, it depends. Mild ptosis is what? Because a small ptosis of like 2 millimeters. That is the surgery for that is what is the name of this procedure? Where you remove. I'm forgetting the name. A mild ptosis, you can do myrilectomy, and there's a procedure where also you do, it's similar to myrilectomy where you excise posterior lamella. I'm forgetting the name. I remember it as you go ahead. But also it's in a bigger ptosis than that. Then Levator resection is the treatment of choice. And then if it's aponeurotic ptosis, then you advance the aponeurosis, and that can treat the ptosis. So as I said, ptosis is also it's a big topic by itself, and probably we can handle it in another topic.
Okay, thank you for that. There is another question. In other subspecialties, maybe like glaucoma, retinoblastoma, there are guidelines. Diabetic retinopathy. What about oculoplasty? Are there any guidelines which someone can use when they are back at their station?
Well, oculoplasty is wide. So there is oculoplasty is wide, and we don't have proper guidelines in most, because we have so many conditions. But we have some set, is it like principles? We actually use the principles as I discussed. Like a problem like ptosis, there are principles and guidelines on the treatment of ptosis. Remember, I talked about when the levator function is good, you can do this. When the levator function is poor, you can do this. If there is mild ptosis, less than 2 millimeters, you can do this. Even in defects, there are guidelines, and I discussed some of those guidelines in this. So oculoplasty is wide, and it's difficult to have if we are to get guidelines, we need to pick several different conditions and treat them differently. There is thyroid orbitopathy. There are some agreed upon principles of management of thyroid orbitopathy. Yes, there are guidelines or principles in treatment of some of these conditions.
Okay. Yeah, I agree. It is very wide and depends on the condition you're treating. So another question from Dr. Nyakagwa. I think maybe you can go through, you had mentioned some of them about which sutures would you use generally, and any recommendations. Are there any specific sutures you'd use if it's in the pediatric age group compared to adults? Especially maybe if they need removal and children are not very cooperative when removing them. So just general overview of which sutures to use, under which conditions, and any difference between adults and children.
Good. That's a good question. I alluded to it, but I will discuss again. As I said, the eyelid itself, especially on the skin, it's always good to avoid large sutures because they leave that trace of the look that there's been a laceration repair that has been done. I prefer using a 6-0. As I said, in adults, I usually prefer using a nylon 6-0. Of course, that has to be removed. Deeper tissues like tarsal plate, I prefer a stronger suture, and mainly 5-0. Occasionally, you can use a 4-0. In children, you are right. You need to avoid sutures that you need to remove. So absorbable sutures have been used. Commonly, people use Vicryl, which is more available. It's a braided suture. But Vicryl has a disadvantages of causing in some patients a granulomatous reaction. And even because it's braided, it has a chance of infection spreading through the fibroids. So it is not the best suture, but availability makes it more used. So it is a suture that you could use. There are some sutures that in children, of course, the teaching for tarsal plate, especially the marginal suture, is you use a strong suture which is non-absorbable. In our case, we use 5-0 nylon. But in children, again, you can still, if you don't want to remove the suture, you don't have to use a absorbable suture. You can use still a strong suture which is non-absorbable, still a 5-0. So what I said is that I prefer monofilament absorbable sutures, including PDAs, monocryl. There are a few examples that we use. If you have them in the setting, I've discovered there are some hospitals that have a lot of those sutures and they don't use. Even in Kenyatta, we don't use them a lot, but they are available if you ask for them, and they are very good for the eyelid surgery, and the outcome is very good.
Okay, thank you for that. I'm not sure if there are any other, oculoplastic surgeons or people who have interest in oculoplasty have anything to add, maybe through the experiences over the years. I don't know if Dr. Washira is in or Dr. Munene. Or Dr. Kabiru. So as you wait for another question, maybe I can put my own question or pose my own question. When you do your any of the grafts, whether it's full thickness or split thickness, what are some of the causes of rejection that you come across or not taking? How do you notice it early, and what could be some of the causes?
Thank you so much for that question. Yes, full thickness skin graft, or mostly we do full thickness skin graft. The uptake is usually very, if you do it well, it is very well. It's very good. One of the contributing factors is making, if the skin, the graft is not well opposed to the bed. In that case, if there is a small gap, and if that happens, or if you get an hematoma, that one can contribute a lot to poor uptake. So as I said, you always want to make sure that there is no dead space under the graft itself. And that one is prevented mainly from a use of a bolster. That really helps in that, and making sure that you don't have a loose tissue of the loose tissue of the grafts. Of course, other contributing factors are infection, so you probably need to be careful with the care that you take. I mean, with the surgery itself to prevent infection. don't cauterize too much because you need that blood supply for it to take. So again, one thing you should notice is that sometimes once you open the graft, I said I open in 5 days. Sometimes it looks so dark. Sometimes you may think it's necrotic. Don't be very fast in removing or moving the graft. It might look like that, and within some time, a small layer just peels off, and you find a beautiful skin under. So that is something you need to be careful about. Thank you.
Okay, so as we come to the end, there's one last, questions are coming. So there's a question about what is the approach you take to lid margin papillomas? That is one. And the second question is, how would you close a skin defect after excision of a small lower lid seborrheic keratosis lesion adjacent to the lid margin without causing ectropion? And can you let it heal by secondary intention instead of suturing?
Good. Good questions. Lid margin papillomas. Those are very common. Papillomas and the nevus. Those two are notorious for the lid margin. The approach to surgery, remember I said in benign lesions, you don't need a margin. So we usually try to just do what we call a shave excision. Shave excision means you cut it flat on the lid margin such that the contour is maintained. If you do that and cauterize and do not suture and don't do anything, it works best for that. That's a good approach for nevus and the papillomas that are small. Papillomas, again, some of them they have a pedicle. So when you excise, you realize that the wound that you've left there is very, very small. The other one is a small seborrheic lesions on the eyelid. Yes, if you do suture, sometimes you can pull the lid down and cause an ectropion. But what I've realized is that if you really must suture, if you think the defect needs to be sutured, because of course when you suture it heals faster, then try to convert the sutures to horizontal in as much as possible. Try to just put them horizontally and in most cases you'll find it's practical enough to suture instead of, even if the lesion looks vertical, there's a way you can convert the suture to be horizontal, and that will not cause an ectropion. There's usually the lid skin is usually a little bit loose, especially if you get an old person, you could easily advance the skin horizontally and cover the defect very well without having to do a vertical stitch. Thank you. I hope I've answered the questions adequately.
Yes, I believe you have. And they have said, thank you very much. So I think we are coming to the end of the tail end of the session. I don't see any more questions. So it's now around 7:30. I would like to pass on the session to Frank Nyakagwa. Otherwise, thank you very much, Dr. NYENZE. Of course, we'll ask you again and again and again. Oculoplasty, you never exhaust all the questions and conditions. So thank you so much for the session, and we'll call on you again.
Thank you everyone who has made it possible, and thank you for the audience for giving me the opportunity.
So Frank, Dr. Nyakagwa, back to you.
Okay, thank you very much. Thank you all. Thank you, Dr. Mukiri, for that wonderful moderation. Thank you, Dr. NYENZE. That has been a superb presentation, very simple, precise. And sure, we'll get back to you. I also want to thank the whole people who have attended the CME. So this time today, we don't have any sponsors. So we have come to an end. No announcements. Majorly, I'll say that for those who have not paid for the OSK membership, that 10,000, pay so that you can be getting your CPDs. Otherwise, thank you. I wish you all a wonderful evening and a night. See you next time in 2 weeks' time for another CME that we'll post. My name is Frank Nyakagwa, and I really want to thank you. So you can now leave at your pleasure. Thank you.